I'd like to bring you down to earth. There are not so many women here. Look around, count 21 women. If we were in Sierra Leone, assuming women were allowed in, one of those women would die during her childbearing years of a maternity-related death. 1 in 21. In a typical European country, such as Switzerland, you'd have to count 17,000 women before you would find one who would die during her childbearing years of a maternal-related death. I looked at the figures for the United States. Why? Because maternal deaths are one of those conditions which ought to be completely soluble by medical care. Which country spends the most on medical care? The United States. Ergo, it should have the best maternal health. I counted 62 countries that have better maternal health than the US. The US has the same maternal mortality as Armenia, just ahead of Georgia, not the Georgia of Jimmy Carter, but the Georgia where Stalin was born. Don't know why that's relevant. Just having medical care doesn't do it. And to see that, let's look at young men in the US. A 15-year-old thinks he's immortal. Given what he gets up to, that's pretty lucky. In the US, the probability that a 15-year-old will die before the age of 60 is about 13%. And 49 countries rank better than the US does. The most medical care, and it ranks around 50 of the 194 member states of the United Nations. Not doing very well. Is that a medical care issue? Or what do young men die of? They die of violent deaths and accidents and drug-related deaths and alcohol-related deaths. Thinking that that's due to lack of medical care is a bit like saying that your broken window is due to the lack of someone to come and repair the window. If someone heaves a rock through your window, they break it. If you haven't got someone to repair the window, it'll remain broken. So we do need medical care when people get damaged, but it's not lack of medical care in the first place that leads to people getting ill. So one problem of health inequities are the differences between countries. The second are the differences within countries. And I'll come back to the Whitehall gradient in a moment. In London, wealthy city, I could get on my bicycle and cycle from Harrods in Knightsbridge, which you have heard of, to Church Road in the London Borough of Westminster, which you haven't heard of. And the difference in male life expectancy would take me about 30 minutes to cycle that distance. The difference in male life expectancy is 20 years. 20 years within the London Borough of Westminster in one of the wealthiest cities of the world. It would be the same in Baltimore or Washington, D.C. So we've got these two huge problems, differences in health between countries and differences within countries. And in order to try and deal with this, I chaired the WHO Commission on Social Determinants of Health. We published our report in 2008, and we called it Closing the Gap in a Generation. Are we bonkers? I'm talking about these vast differences in life expectancy within countries and between countries, and we want to close the gap in a generation. It was a statement that we have the knowledge and the means to close the gap in a generation. The question is, do we have the will to do it? And we had three domains of recommendations. improve the conditions of daily life, deal with the inequities in power, money and resources that give rise to inequity in the conditions of daily life, and the importance of knowledge, understanding, training, capacity development. And we said that a toxic combination of unfair economic arrangements, poor social policies and programs, and bad governance is responsible for these inequities in the conditions of daily life that give rise to avoidable inequalities in health, which is what I mean by inequities. And by using the term inequity, I think it's grossly unfair that we could make a difference and we don't. And in the wake of the WHO Commission, I was invited by the British government to ask how could we apply the findings and recommendations of a global commission to one country, England. And I called my report Fair Society, Healthy Lives. It was a statement that if we put fairness at the heart of all policy making, health would improve and health inequalities would diminish. And in fact, my criterion of fairness is taking action on avoidable inequalities in health between social groups. So when a politician says, we did it because it's fair, and they cut the top rate of income tax, I say, will that reduce avoidable health inequalities? If they say, we did it because it's fair, and they cut tax credits to the poor, I ask, will that reduce avoidable health inequalities? If they say we did it because it's fair and they cut social services to the disadvantaged, I ask, will that reduce avoidable health inequalities? At the heart of this concern is one of social justice, but the evidence really matters. And this is the kind of evidence you heard in the introduction, where you are in the hierarchy in the British civil service relates to your health and longevity, not just amongst civil servants. This is the whole population of England. Each dot here represents a neighbourhood in England. The top line is life expectancy, and the neighbourhoods are ranked by deprivation and affluence. So at the right-hand end, you have the most affluent. What you can see is people near the top have shorter life expectancy than those at the top. People in the middle have shorter life expectancy than those near the top, all the way from top to bottom. Now, when we talk about inequities in health, it's common to think of the poor. The poor do have poor health, and it's one problem that we have to deal with. But this is not about poverty. It's about inequality. The people near the top have access to healthcare, free at the point of use. They're in no way poor. People in the middle have access to healthcare. They are in no way poor, but their health is worse than those above them. We have to grapple with the question of inequality, not just poverty, and ask, how does inequality relate to health and well-being? And sorry, the bottom graph is disability-free life expectancy. And you can see the gradient is steeper. So it's not just length of life, but quality of life that matters. Now, we're always going to have inequalities in society. If health follows that social gradient, won't we always have inequalities in health? Well, yes, probably we will. But the magnitude varies. SE is Sweden, and EE is Estonia, Hungary, Romania, Bulgaria. Forgive me for the labels. This is education. So 0 to 2 is the basic level of education. 5 to 6 is university education. It's a gradient, but I've just got the top and the bottom. So you can see that in Sweden, long average life expectancy, and small difference between the top and the bottom. In Estonia and Hungary, lower average and a big difference between top and bottom. But what you can also see is that the difference between countries is bigger for those with primary education than it is for those with university education. Imagine you were a parent in Hungary and you say to your young child, you must do your homework so you can go to university and live a long life. And the child says, I'm a child, for goodness sake. Why do I care about a long life? I want to nourish my soul and gladden my heart and smell the flowers. This is a very lyrical child. Why do I care about a few more years of life expectancy? And you say to your child, no, you misunderstand. It's not the extra years that matter, but if your life has better quality, all the good things about life, you will live a longer life. So life expectancy is a measure of how good your life has been. Says the child. Well, if that was so important, why didn't you arrange for me to be born in Sweden rather than Hungary? And you say, be quiet and eat your vegetables. And the child says, pulling rank is the last refuge of a scoundrel. This is a very special child. Okay, good point. So the child then says, okay, if I get more education, I get a longer life. I want to know why it makes a bigger difference learning irregular verbs in Hungary than it does in Sweden, because education seems to make a bigger difference in Hungary than it does in Sweden. Why do I need to learn irregular verbs here? Good point, you say to this child, good point. Education does two things. Always and everywhere, education empowers you, helps you have control of your life. But it does something else. Education gets you a better job, more income, a better place to live, all of those good things. Now in Sweden, the difference in those good things between people with more and less education is very small. Everybody has reasonable employment, a decent place to live. I've visited slums, so-called, in Sweden. These are slums done by the Swiss. These are not slums that you'd imagine in other countries. So everybody has a decent place to live. So the difference between those with more and less education is much less. In Hungary and Estonia, it's much bigger. Aha, says the child. You mean if I go to university, that's like going across the Baltic to Sweden? You're halfway there already, you say. And we see similar differences in women. Now, to deal with this, we say that every sector is a health sector. In other words, it's the conditions of daily life that make a huge difference to health. And that means it's not just for the health sector. In my English review, we had 6 domains of recommendations. Give every child the best start in life, education and lifelong learning, employment and working conditions. In a rich country, everyone should have the minimum necessary for a healthy life. Healthy and sustainable places to live and work, and taking a social determinants approach to prevention. Let me just show you an example. Early life. These are measures of children's socio-emotional difficulties at age 3 and age 5, classified by the income level of the parents. And what you can see is the lower the income level of the parents, the greater the frequency of social and emotional difficulties at age 3 and age 5. Then we asked parents, is it important to cuddle a child? About 20% of parents aged 3 deny that it's important to cuddle a child. And that follows the social gradient. We asked, is it important to talk to a child? About 20% of parents deny that it's important to talk to a child aged 3. And that follows the social gradient. Cuddling, talking, playing, singing, all of those things, the lower in the social hierarchy, the less likely are parents to endorse the importance of interacting with the child. And that explains about half of the social gradient in social and emotional difficulties. Now, we've been monitoring this over time in England as a way of keeping the politicians up to the mark. And if we look at the proportion of children with a good level of development at age 5, it follows the social gradient. The more deprived the area, the worse children age 5 score on these measures of good development. But there's a lot of scatter around the line. And that suggests two strategies. One is reduce deprivation, reduce inequality. And you'll reduce the inequality in early child development. You'll bring the more deprived up. And the other, given the scatter around the line, it means for a given level of deprivation, some are doing better than others. The kinds of things I talked about that parents can do, services can do. If parents are ground down by misery, poverty, scarcely literate themselves and can't read to children, we can support parents. The evidence shows we can make a difference. But the other is we can reduce poverty in childhood. What this graph shows is poverty, where poverty is defined as less than 60% median income, before and after taxes and transfers. So if you compare Latvia and Sweden, before taxes and transfers, about 35% of children in Latvia are in poverty and about 32% in Sweden. After taxes and transfers, the poverty level in Latvia is still up at 25%. In Sweden, it's 12%. In Slovenia, not a rich country, it's lower. I showed this figure at a big meeting in the US, said you might like to know what it is in the US. After taxes and transfers, child poverty level is higher than in Latvia. And I looked at this vast American audience and say, you live in a democracy. This must be the level of child poverty that you want. Otherwise, you'd vote in a government that would do something different. Clearly, you're tolerant of high levels of child poverty. In Slovenia, they're not. And in Sweden, they're not. They choose to make child poverty less. We talk about empowerment. At the heart of what we were trying to do is empower individuals, communities, and indeed whole countries. Look at this example from British Columbia in Canada. Adolescents from First Nation communities, Aboriginal communities in Canada, have about 2.5 times the suicide rate of other young Canadians. But suicides in young First Nation Canadians are not distributed evenly through communities. These researchers looked at different First Nation communities and classified them by whether they had self-government or whether they were involved in discussions about land claims, and whether the community controlled health services, education, cultural facilities, police and fire services. What you can see is the more of these cultural factors that were present, the lower the youth suicide rate. When communities are disempowered, chillingly, young people kill themselves. This is really ghastly. Empowering communities is a matter of life and death. Is anybody listening? Well, it turns out people are listening. I produced this report in England, the Marmot Review, Fair Society, Healthy Lives. The King's Fund in England did a survey of 65 local governments, health and well-being boards, and asked them what was their number one priority. And 49 of the 65 said Marmot principles. I met a local government person from Manchester in England. She said, "You're Marmot." I didn't realize Marmot was a person. We talk about implementing Marmot. So we're on the agenda. Malmö in Sweden did their own Marmot review for a socially sustainable Malmö. And I was absolutely delighted. I had the honor to hand a copy of our Closing the Gap in a Generation report to, he's now the former Prime Minister, the Prime Minister of India, Manmohan Singh. He said, "What would you like me to do?" I should tell him what to do. He's the Prime Minister of 1.2 billion people. I said, "Well, we think we've got a way to make India healthier." And my colleague, Mirai Chatterjee, who's in that photo, tells me it was as if they were working their way down through our recommendations and implementing it in India. Costa Rica is about to set up a commission on social determinants of health, and we're going to advise them. And the mayor of Lima in Peru, likewise. We did this European review of social determinants and the health divide. Now, the European region of the World Health Organization includes all of the former Soviet Union. So it stretches so far to the east, you can practically touch Sarah Palin in Alaska, which is pretty scary. And we said that if you're a country that's doing very little on social determinants and health equity, do something. It would make a difference. If you're one of the newer member states of the European Union, if you're Poland, do more. And if you're Sweden and Norway, which still have growing health inequalities, do it better. There's something here for all of us.